Welcome to Cardiovascular Diagnostic Tests. This is a review and summary of basic cardiovascular diagnostic tests. Our standard disclaimer is there to the left and basically says we do the best we can to provide accurate and current information, but this video is not designed to replace your professor's information, but instead to supplement. So we're going to cover all of the basic diagnostic studies that we see in cardiovascular. So we'll start with the simple things. Chest x-ray. Remember that chest x-ray only shows us certain things. It shows us size, anatomic changes, and fluid that might be around the heart or the lungs. So the picture that you see there shows actually severe heart failure. So it doesn't tell us where there's damage in the heart muscle. And so a lot of times questions that are asked on exams about diagnostic studies are looking for a couple of things. It wants to know, do you know what the test involves? Is it going to be painful? Do they have to be NPO? Are they going to need sedation? Those kind of things. It also wants to know, do you know what this test is typically used for? So make sure you keep that in mind as you're listening to the various diagnostic studies. The next thing is ECG. Of course, all of us old people call it EKG, so it's the same thing. So electrocardiogram. This can show us several things. It shows us dysrhythmias. It can show us if there's hypertrophy or pericarditis, if they've had an MI. ECG itself can show us an MI and where it occurred. So it's very important to realize. It can tell us if their pacemaker's working well, or the drugs we're giving them working well. Typically, if we suspect an MI, then an ECG is done serially, meaning in succession. So usually every 2 hours, maybe every 4, maybe every 6 hours. And we look for changes, and so we can see changes in the pieces of the ECG, the QRS, the ST, the T wave, and we see those things with ischemia. We see a pathologic Q wave with a STEMI and no Q wave with a non-STEMI. All things you'll learn about in dysrhythmia and the video about acute coronary syndrome. The thing you should know about ECG is it is the quickest, most accurate way to show location of an MI. This is a common thing to test on, and a lot of times students want to jump to cardiac cath, but think about that. Cardiac cath is invasive. You got to be in a place where you have that facility. Not every facility can do cardiac caths. So ECG is much faster and safer, quickest, most accurate way to show location of an MI. Now, a Holter monitor and event monitors are a type of ECG monitoring. So a Holter monitor, and that's just an example of one in the upper right corner, is a continuous ambulatory ECG, and it gives us diagnostic info over a period of time. And ECG tells us what's happening right now at this very moment. But a Holter can tell us what's happening over the course of 24, 48 hours. It's not invasive. The most they have are the little stickies on their chest, so typically when they go home with this, they can't bathe for 24 hours. And we do this monitoring when they've had symptoms, maybe shortness of breath or fluttering in their chest, and it's kind of at varied times. And so they can put them on the Holter monitor for 24 to 48 hours at home and see what's really happening. And they would monitor their symptoms. They had symptoms, they'd mark it, that kind of thing. An event monitor or a loop recorder is useful if there's less frequent events. So maybe they have symptoms, but it's maybe once every 10 days, and it's not any kind of pattern. So because it's not as often, we need to monitor for a longer period of time. These can be external, one for a month, and then it will only record when the patient activates it. So if the patient's having symptoms, they push a button, it starts recording, and it has a delay, so it can record seconds before they marked it with the symptoms, and it'll record for a time period after the symptoms, so that you can kind of track it. There's also an implantable one, and that's what you're seeing here on the right, that of course is indefinite, and it will record when something happens. So when it gets triggered by a dysrhythmia, it would record slightly before, slightly after. And these can also be used for telephonic pacemaker checks and other things. The exerciser stress test, the picture that you see there in the lower left, this will evaluate the heart's response to physical stress. So oftentimes people that are being worked up for cardiac disease will have this done. People that have existing cardiac disease oftentimes have this done once a year to monitor their progress. So the other thing it will do is define limits for exercise programs, because just because cardiac disease doesn't mean you shouldn't be exercising, but it means your limits might be different. So they can use the exercise stress test to decide what is your highest heart rate you should get to before you need to settle down from exercise. So there are oftentimes questions asked about this, and here's what you need to remember. Anybody, whether they have a good heart or a bad heart, is going to have some sort of symptoms when we put them on a treadmill, right? What happens to you when you get on a treadmill? Your blood pressure goes up, your heart rate goes up, you get a little tired. So oftentimes I see a question asked where it'll say the patient has fatigue and increased heart rate and blood pressure. Do we need to stop the test? So the answer would be no, you don't stop the test, because that's what we expect to happen. So then that means, when do they stop the test? And usually it's if the ECG is showing hypoxia to the heart muscle or dysrhythmias that they would decide to stop that test. So just make sure you keep that in mind. Continuing on, echocardiogram. That's the picture you see up here in the upper right. You have to look pretty closely, but you see he's got a little ultrasound device, and he's just putting it on the man's chest. He's wide awake, it's not painful, and then he's watching on the screen. So generally, an echocardiogram is not painful. It just uses ultrasound waves, so they'll have the little bit of the jelly on the chest. Sometimes they'll turn the lights off, the room will be dark. Occasionally, they use an IV contrast, so we want to make sure we know whether they're doing that or not with an echocardiogram, but that is not the norm that everybody has that IV contrast. So the great thing about echo is it gives us a lot of information. It tells us about the structure of the heart. It can tell us ejection fraction, so how much blood the heart is pushing out. Tell us a lot about the valves and blood flow. And it shows color and sound. So when you look at them, you can see red and blue to see the oxygenated blood and the unoxygenated blood. And you can hear heart murmurs with them. So it's a great test. And we can also do a stress echo. So with a stress echo, people that really can't exercise on a treadmill, we can give them an injection of a drug, which will speed up the heart, raise the blood pressure, and then see how the heart responds to that. So echocardiograms really tell us about wall function. So in terms of an MI, they don't do it to determine where an MI occurred immediately. After they've been diagnosed with a heart attack, they might do an echo to see how well the walls are functioning. So it's not usually done to diagnose a heart attack. TEE, or transesophageal echo. Now make sure you know the difference, because this one is a bit more invasive and requires sedation. So anytime we're going to give sedation for a test, then we are also going to make them NPO, because we don't want them to have any food in their stomach when we sedate them. Alright, so the TEE gives us more precise information than just a straight echo, because you actually are going behind the heart. So if you look closely at this picture on the right, you can kind of tell when they bring that tube down through the mouth and down the esophagus, it comes in behind the heart, and so we don't have any interference with the chest wall or the lungs. Again, this requires sedation and NPO for 6 hours, because they pass that transducer probe through the esophagus. Sometimes they will do IV contrast with this. Typically, this is an outpatient procedure. They can do it while they're in the OR for something else, and they can do it in the ER usually. Next is nuclear cardiology, or MUGA. This is pretty common. It provides structural information and ejection fraction. And then they can do perfusion imaging where they really look at that blood flow to diagnose coronary artery disease. So what this test involves is injecting a radioactive isotope. So they typically they might have just a straight isotope they inject with a butterfly needle, or they might draw some of the patient's blood, mix it with the isotope, and then re-inject it. So then they watch the blood flow with this isotope in it, and they may repeat scans within a few minutes or even several hours after they inject. So make sure you understand that so that you don't get these tests mixed up. So typically they've got to lay still in the machine like you see here on the right with their arms up over their head, and then they may have repeat scans of that. MRI is not super common with cardiac disease, but it is sometimes done, and of course you know with MRI it's non-invasive, but you have to lay very still. It's very loud and noisy, lots of banging. You absolutely cannot have MRI if they have a pacemaker or an implantable cardio defibrillator, ICD. They cannot have an MRI at all. That's important to remember with cardiac. It can also, MRIs let us see really small things, like a small MI that maybe they couldn't diagnose another way. It also can help predict how well they're going to recover after the MI, but they do not use it to diagnose CAD. CT would be more common to do than MRI probably, and it will visualize the heart anatomy, circulation, and those vessels. It may or may not involve IV contrast, so it can and it cannot. There are some things that we can do instead of CT, and CT is actually can oftentimes now be performed instead of a cardiac cath, and so you don't have the risk with cardiac cath. It's non-invasive, but if you find a problem with the CT and you need to fix it, you can't just jump in. So with a cardiac cath, if we find that they need a stent while they're in there looking, they can go ahead and put a stent or do an angioplasty, and you obviously can't do that with CT. So if they find a problem, then the patient has to go on to cardiac cath. So sometimes if they're not sure if there's an issue, they might choose to do a CT first instead of a cardiac cath. Another thing that we know about CT with cardiac is the calcium score screening heart scan. And we're seeing a lot of these on mobile sites now. And what this does is it detects early calcifications, so it's a predictor of whether you might have a cardiac event. Again, remember, no sedation, no NPO, typically not an IV, although they might do contrast. Very quick, low risk, get results fast. Now, cardiac cath. Cardiac cath is very important for you to understand. I always ask my students questions about cardiac cath because we see them done so often. This is still considered the gold standard for coronary imaging, and it is invasive, typically outpatient, and it involves insertion of a very large catheter, like a garden hose size, not really that big, but it would feel that big probably, a large catheter into the right or the left side of the heart. So they can sometimes use an arm vein, but they typically use the femoral vein. And so on the right side, they would go up to the vena cava, to the right atrium, to the right ventricle, and then up into the pulmonary artery. So they would also be able to look at the left side of the heart. For the left side of the heart, they use the femoral or the brachial artery. Again, we're not seeing the arms used as much, but we may start to. I saw a new study on that. And then they go in the aorta and look into the left ventricle if they're looking at the left side of the heart. So it tells us lots of things. It shows structure, it shows pressures, cardiac output, ejection fraction. If they use dye and do an angiography, then they can look at the coronary arteries themselves. It just gives lots and lots of information. Remember, anytime you see the term angiography, that they're injecting dye, iodine, so you must ask if they're allergic to iodine, into the arteries. And when they do that, it makes the patient feel real flushed, hot, and feels real warm, and then that lets them look for are there blockages. With the angiography, they can also do an ultrasound there and look deeper into the heart. Fractional flow reserve uses a wire, so while they're already in there, they can thread a wire up into that catheter to measure pressure and flow in the coronary artery, and then it helps them decide if the patient needs angioplasty or do they need stenting. EPS, or electrophysiology study, is another thing they can do while they're there, and it looks at the electrical activity of the heart with some electrodes. What that does for the patient is it really helps determine where our dysrhythmia is coming from. And that's done very similar to a heart cath. So when you see EPS study, know that it's invasive and they're going to have that catheter in, and they look at those dysrhythmias. So as you can imagine, there are complications with this procedure and risks, particularly bleeding or hematoma where they put that catheter in. They could have allergic reaction to the dyes. Of course, everything has a risk of infection, but it isn't particularly high risk. Clots. So not only can you risk bleeding, you can risk getting a clot in that same part where they put it in. Some very serious things that could happen is a dissection of the aorta, dysrhythmias, because you've got that wire up in their heart and you might touch the side of the heart wall and stimulate a dysrhythmia. Pretty common, but they're there watching and ready to give medications. They could, though, cause an MI or a stroke if they put that catheter up and they dislodged a plaque while they were there. And then also very unlikely but possible is to puncture one of the ventricles of the heart or to puncture the lung, both of those would be very, very bad, of course. So really important that you understand nursing care with a cardiac cath, because we do get a lot of these patients back and monitor them afterwards. So NPO, because they are going to get sedation. So before, they've got to be NPO. And then we want to know if they're allergic to iodine because of the dye that they'll give. They're told about this while they're there, but it's important for you to know, too, that sometimes when they give the dye, they ask them to take a deep breath, or they might be asked to cough during that. If they're having the electrophysiologic study, oftentimes they have to stop antidysrhythmic meds before so that we can see where those dysrhythmias are occurring, and that, of course, has some risk to it. Afterwards, when they come back to you, and I'm going to use the groin as an example since that's where these are most commonly done, we've really got to check that leg. So I have a picture of a sandbag. Not everybody uses sandbags anymore, but sometimes they will come back with a sandbag over that site. A lot of times now they use what are called physiologic plugs, and those are put in by the surgeon to stop bleeding, and then they absorb. But regardless of that, when they come back, they're going to be the site usually has a clear dressing or a foam tape, like a pressure dressing, so you can't always see it, but there's a big risk for hematoma, so you have to feel over it every 15 minutes too and check that site to make sure nothing's happened. I think these might be our last two, and these are blood flow measurement studies. So duplex imaging is commonly done in people with peripheral vascular disease, or someone maybe that we think has a DVT or a venous thromboembolism, one or the other, where they'll go in and use a combination of ultrasound to look and see, do they have blood flow going through the vessels, particularly in the legs. They will sometimes inject contrast media for this test. And then lastly, hemodynamic monitoring. This will be talked about in great detail in critical care for cardiac, but just so you know in general what it is, as you see here, a picture of just a monitor. And this monitor is connected to a catheter that is inserted into usually the vessels of the neck and then threaded into the heart. So sometimes it's wrist for just blood pressure monitoring, but it does require insertion of a catheter, and that catheter takes various pressures, capillary wedge pressure and pulmonary artery pressure, all these different pressures, and really monitors cardiovascular status immediately. And so you can give drugs. You only do this in the ICU. You can give medications, see the immediate response, and make it an instantaneous change in the medication. So it's for very close type monitoring in the ICU. Back on duplex imaging, very important that you see if they are allergic to iodine because of the use of contrast. Watch for more cardiovascular videos coming soon. Check out our website, pocketprofnursing.com, where I put more videos, I put links to videos, and I put games to test your knowledge. And then watch for our app coming soon. As always, we appreciate your feedback, so feel free to write comments. I always respond to those. Like or dislike the video, share it, and subscribe to our YouTube channel so you'll know when we have new videos. Thanks for watching.